Thank you. And I am desperately trying to hold on to the last day of November, as you can see with the fall. I have not transferred it over to the December backgrounds just yet. All right. So I was given a lot of autonomy for the topic today, psychotropic medication use in youth. And I really struggled with where do we start? The last presentation that I gave was focused on ADHD medications, and there really wasn't anything necessarily that caught my eye that was necessarily new and robust. But the prevalence rates, as well as how often we're using medications, and the fact that the workforce is not quite meeting the demands that we have, really were up front in most of the literature. So it's not going to be focused on how any of the meds work, but really looking at some of the usage rates, as well as approaches that we're taking to try to meet some of those unmet demands. So from an objective perspective, I am going to spend some time looking at the prevalence of use. What is it that we're seeing? What did the trends look like? What are the main reasons that they're using some of the medications? So for some of the most frequently prescribed classes of medications, what are the indications that we're looking for? And then I really am hoping to provide, I wasn't sure how to describe this, so information is what I said, but I think it's more questions or approaches for you to feel more comfortable in assisting and supporting the youth who are using psychotropic medications, as well as their families and caregivers. So that's the plan. That's the plan for this morning. I like to start with definitions just to make sure everyone's on the same page. So in talking about psychotropic medications, that was the title that we're using. So psychotropic medications are defined by dictionary.com as affecting mental activity, behavior, or perception. I recognize that that's a very broad definition that technically would also include a number of other substances that aren't necessarily prescription medications. And that's not totally where I'm hoping to go with this. So I like the World Health Organization's definition a little bit better. So it's medication that's used to treat symptoms of mental disorders, to reduce disability and prevent relapse. That really is much more of the direction. Yes, the medications have an impact on individuals' mood, their thought process, maybe some of the symptoms that they're experiencing, but really the goal is that we're using these medications as a component of a bigger plan to help the youth for whatever condition it is that they're experiencing. Now, what falls under that umbrella of psychotropic medications? Well, there are several classes. This is not a total, full, and all-inclusive list, but some of the broad categories that you'll see and that I will bring back up a little bit later. We have medications that are used to treat attention deficit hyperactivity disorder. So alpha agonists and the stimulants. Alpha agonists are things like our clonidine, the Capvey, our guanfacine, the Intuniv, and stimulants being things like methylphenidate, Ritalin, or our mixed amphetamine salts, things like Adderall. Our antidepressants, antipsychotics, medications for treatment of anxiety, benzodiazepines, which kind of get their own class because we can use them for a few different things. Our mood stabilizers, so things like lithium that really are an attempt to help keep the mood from reaching the extremes. Some of the antipsychotics fall into that category sometimes. We have our sedative hypnotics, things for sleep, as well as treatments for substance use disorder. So there really are a robust number of classes of medications that fall into this category. Recognizing that there are several of them, how often is it that we're using these medications in youth? This is data from the National Health and Nutrition Examination Survey, so it's also called the NHANE survey. The most recent data I was able to find was this compilation from 2005 to 2010, specifically looking at youth. They found about 6%. So in this particular trial, they were surveying and just looking for a number of individuals who are taking any of those medications for a mental health condition. It was about 6%. So 6 out of 10 individuals were on a psychotropic medication. Most of them were just on one, which was encouraging. Youth were considered individuals who are 18 years of age or younger, and there was less than 2% that were on more than one psychotropic medication. This is looking at the whole cohort, so looking at a whole group of individuals and all of the kids in general. So you may think that those numbers look a little bit different from the youth that you may be serving. When they broke it down for what medications are being used, the most common at about 3% were antidepressants and medications that are used for the treatment of ADHD. They didn't see quite as much of antipsychotic use or those for anxiety or mood stabilizers. Now, I do want to point that out because the survey data is from 2005 to 2010. So some of those numbers may have shifted a bit, and that was why I was hoping to find more updated information. The biggest cohort I was able to find that looked at more updated information was actually from individuals in Canada. So they did a cross-sectional study from the Manitoba Center for Health Policy, and this particular health system could look at all of the claims data in their particular catchment area. So since they do have nationalized healthcare, they had a much more robust database. Now, they were looking at the span of time of 2015 up through the end of 2020. They were looking at prescribing trends for youth, those that were 18 years of age or younger. The average age was about 8.5. And they captured the information quarterly. So they did evaluate this quarterly, and there were more than 330,000 youth that were included in this. The top line, I was going to say top bar, but it's not really a bar. So this top line is stimulants. So again, those medications that we're using for treatment of ADHD. This is prevalence per 100,000 individuals. When we actually convert that to a percentage, it's still about 3%. So that actually looked fairly consistent with what we saw in the NHANES data from the United States previously. There does look to be a slight trend up, which is consistent with some of the trends that we've been hearing, but it doesn't look like it's been a very steep curve. So usage rates are increasing slightly, but we're not seeing huge takeoffs. The next line here are antidepressants. So these would be things like fluoxetine or Prozac, sertraline or Zoloft, and there has been a steady increase over time, over the last 5 years. That also has been pretty consistent. This number actually is a little less than 3% that was seen in the NHANES trial. So it is possible that this is slightly underrepresented in a different cohort. But it does look like the use of those antidepressants is also increasing. For the bottom two bars, our orange or yellow bar are the antipsychotics. So these would be medications like your Risperdal or Risperidone, your aripiprazole or your Abilify. That looked relatively flat. Interestingly, when we look at large groups, more public health cohort data, it does tend to stay relatively flat. But as we start to drill down, we'll see that that actually is trending up for certain targeted groups. The light blue line at the bottom actually looks like it's trending down slightly, and that's for some of our anxiolytic and sedative medications, so those that treat both anxiety and for sleep. There has been a hope to move away from that, potentially using some new natural or supplemental medications, things like melatonin, trying to use non-pharmacologic agents, especially for sleep disorders in some youth. So looks consistent. Antidepressants, ADHD medications look to be the most common. Overall usage rates look pretty steady, but there may be a slight increase, at least when we look at the general population. My concern with looking at the general population is I don't think that tells us for some of the high-risk individuals, some of the kids that you very likely are working with. I was able to come across this poster presentation. So this was data that was presented at the American Academy of Pediatrics in 2021. It was an evaluation of Medicaid managed care claims. Now, this was looking at Medicaid claim data in the state of Texas. They looked at all of the children between ages of 1 and 18. And again, they had almost 400,000 youth. They split them between all of the youth that were in the Medicaid system, as well as youth that were specifically in the foster care system. So they wanted to look and see if there was a difference between the two, because there have been some suggestions and other reports previously that said that individuals in the foster care system seem to have higher prescription rates of psychotropic medications. These individuals had to have been had insurance for at least a month and at least one healthcare claim. So there had to be some type of engagement with the healthcare system. When they looked at these results, they found that, so alpha agonists were those ADHD medications. Those that were in the broader cohort, it was about 1.3%. It was almost 20% for those that were in the foster care cohort. For anxiety medications, it was about 3% in the general cohort, about 6%, so not quite as much of a difference with the foster care patients, the kids who are in the foster care system. Antidepressants, we again see a big jump, less than 2% for the general group and almost 18% for those in foster care. Antipsychotics, this was more of what I was expecting. So yes, that Manitoba line looked relatively low. It was less than 1% in the NHANES trial. This is where the problem is. So if we look at general public data, we're not seeing the trends that we see in high-risk populations. So for the kids in foster care, 1 in 5 are on some of those antipsychotic medications, which was much more about what I was expecting to see. And then about 20% of those individuals who are on stimulants. So why do I bring this up? I think it really is important when we're talking about psychotropic medications, what population it is that we're talking about. If we're looking at general health global data, you're going to have folks that are saying, you know, those rates really aren't that high. We're not seeing that frequently. But taking a step back, more of what you're involved with every day, that's where we see those percentages being much higher. And we just want to really be sure that the medications that are being used on this frequent basis are being used intentionally for the right reasons, that we're actually getting benefit, because all medications come with adverse effects. So with that in mind, they actually broke down this data based on age group. I think, at least for Texas, the good news is that they weren't seeing a lot of really young patients on some of their psychotropic medications. We have a little bit better data with kids that are more school-aged or older that are on some of these medicines. Their brains are still developing. So they would be able to target specific populations for interventions, education programs to make sure we're using these effectively. The state of Ohio is also working on this. There was a group of individuals that were brought together to provide some information to the managed care organizations. They have not publicly released all of that data, but I will say that they have high-risk patients who also have some of this breakdown. It looks relatively similar to what this Texas data looks like. How can we use that, though? So knowing that there are higher risk populations, what is it that you're supposed to do with that information? I think having a consistent approach. There are several individuals who may say, you know what, meds aren't my thing. This isn't what I was trained in. I may not necessarily feel most comfortable. I'm going to challenge you with my last final slides here, that you really are part of the solution. We need all of you to be part of the team. And while years of pharmacology and pharmacokinetic training may not be in your future, there are some steps that I think everybody can take that would really be valuable to the folks that are overseeing the medications. I boil them down to 4 steps: defining the symptoms, establishing baseline, determining follow-up, and collecting and sharing information. I boiled them down to these steps because I think that very frequently, for those of you who have gotten recommendations, these tend to be some of the recommendations that I bring forward. So I want to give you 2 brief looks at how those steps may interface. So I told you the 2 most frequently prescribed medication classes are medications for ADHD and our antidepressant medications. So those are the 2 examples we're going to take a peek at. So what would this look like if you get a youth who has medication for ADHD? Okay, what does their ADHD look like? They could look incredibly different. What are those target symptoms? What is it that has been most problematic for this child that we're trying to make a difference for? Is it inattention? Is it hyperactivity? Is it impulsivity? Does it look like something different? But making sure that that's clearly described, because oftentimes it's like, well, we're using this for ADHD. Okay, but that doesn't narrow it down enough to know exactly what we need to be monitoring for this youth. And then establish a baseline. What is it that's going on that's most problematic? I worked at an intellectual disability clinic when I was in New York. We had a preschooler who was in the clinic who was brand new to us, and his hyperactivity was out of control. He often would be able to run out of the room. He required a one-on-one because he was very impulsive and hyperactive. He would get himself in trouble. He would hide in different places. The one day he was successful in pulling the fire alarm 3 times. The first time he had run out of the room, pulled the fire alarm. The second time he was in a room with 2 adults who were specifically speaking with him and observing him, and he still was able to get away and pull the fire alarm. The fire trucks had not quite cleared the block and just turned around and came back to our clinic. And then he was able to do it again with a number of individuals in the room. So his hyperactivity was impairing his ability to function. It was happening very, very frequently, and it was incredibly disruptive, and it was disrupting his ability to have any relationship with either his peers or the adults he was working with. So capturing that's what his baseline is. That's what we're hoping to see a difference in. Because if we don't have that baseline, if we don't have something to compare to, then it's really tough to know if the medications are working. For ADHD, we have a handful of different agents that could be used. Our stimulants, they work really quickly. So if we know that hyperactivity is an issue, the youth starts taking that medication. Did the hyperactivity change? Are we seeing anything? Are we seeing any improvement in the hyperactivity? Can they sit still for a shorter period of time? Are they able to engage in other activities without immediately giving up and moving to something different? And are we seeing something different? Are you noticing irritability? Are there any new adverse effects? Did it make the hyperactivity worse? Maybe it's not ADHD. Maybe it ends up being anxiety that just has manifested as hyperactivity, and we're kind of pouring gasoline on the fire to make that worse. That's really helpful information. So being able to collect that information and give that back, but also recognizing time frame. So if we're following up pretty quickly because new medicine's been started for ADHD, if the youth was started on something like atomoxetine, which is our Strattera, or something like clonidine, and we bring them back in a few days, a week, and we say, we're not really seeing too much of a difference, well, that may not be a failure of the medicine, because those medicines take a little bit longer to work. Whereas with the stimulant, if we're not seeing anything at that time frame, then okay, maybe we do need to look at making some modifications. But making sure everybody's on the same page with that can be incredibly helpful. If you're giving efficacy data, no, the hyperactivity has not changed at all for something like the atomoxetine, but they're really hoping for the adverse effect information. Are they anxious? Did they, have vomiting? What's their appetite look like? Then there's going to be a bit of a discrepancy, and that can cause frustration overall in the team. And sometimes that makes the medications kind of fall apart. So it's just really helpful to work through those 4 steps. So what are the symptoms? What is the baseline? When are we checking in? And then how do I get you the information that you want at that check-in point so we can make sure it's doing what we hope that it does. So just as a reminder, those are the 4 steps. Same thing with antidepressants. So what are our symptoms? We can use those for all kinds of different indications. What was the baseline? Is it better? Is it worse? And recognizing if we're checking in right away, it's probably not going to be better. And if they're using it for anxiety, sometimes that gets worse in the first week or 2. So recognizing that we really have to support them to push through those first couple weeks before we can see if the medication is going to be beneficial. So why do I reinforce that with both of those? Because there are significant unmet needs. So there was a national survey done of children's health. This was a parent proxy survey. It collected information on more than 46 million children. What they found is in the United States, the prevalence of mental health diagnosis is about 16.5%. So big general cohort population, there's a lot of them. And of that 16.5%, about half of them are not receiving treatment. They're not receiving any treatment whatsoever. And if we look at Ohio, we're unfortunately on kind of the upper end of that number, where almost 50% of those youth who have a diagnosis aren't engaged in treatment. In order to close that gap, they really are recommending that we look in diverse areas. How can we optimize the treatment and utilize all the resources that are in place? So they're relying much more heavily on primary care and pediatricians in places where there aren't enough mental health care providers, there aren't enough psychiatrists. So coordinated care, integrated care initiatives like Ohio Rise really are essential to be able to close that. That gap exists. That exists currently. That data is actually only a couple years old. So recognizing that that's there and we need all hands on deck is why I am challenging you to try to use some of those approaches, those strategies to ask questions about the medications so that we have everybody on board to help support those individuals and lower that number so that it's not almost 50% that are untreated, but that we're really adequately treating as many as possible. So with that, I'm going to stop my share and I will turn it back over.